4, 3, 2, 1. Sir, you are live.
Hello, good morning, good afternoon, good evening. I welcome all the faculty of Asia Pacific Hip Society and the participant to this exciting series of complex primary total hip replacement. Today's webinar is on total hip arthroplasty in ankylosed and fused hip. I'm Dr. Shahid Noor. I'm the current president of Asia Pacific Hip Society, which is a section of Asia Pacific Orthopaedic Association. Co-host with me is Professor Abhay Elhence, who is going to moderate this session. We have top faculty who have wide experience of dealing with these complex cases. With me is Professor David Chun. He is the past president of Asia Pacific Orthopaedic Association, and he is the president-elect of Asia Pacific Hip Society. With me is Professor Rami Sorial, who is the past president of Asia Pacific Arthroplasty Society. Professor Amin Chinoy, Professor Rajeev Sharma, Professor Rajesh Malhotra, Mr. Mehul Acharya, Mr. Nikhil Shah, and Mr. Zhang Zian. So these are faculty from around the globe, from Australia, from UK, from Singapore, from Malaysia, India, and Pakistan. So this is going to be a very interactive session. We are going to have few short presentations. This is going to be a case-based webinar where there'll be a lot of opportunity of question being asked among faculty and participants. So please post your question and we are going to answer. So I'm handing over the mic to my colleague co-host, Professor Abhay Elhence, who is going to introduce individual faculty, and we'll have the presentation. So have a good time. Thank you.
Thank you so much, Professor Shahid, sir. Very welcome to all the faculty and also to the audience across the Asia Pacific. This is a fantastic series of webinars, and without wasting too much time, every one of us knows and is well aware of who Professor Rami Sorial is, exceptionally achieved professional, and I would request Prof. Rami to please start his presentation. Thank you, sir. Prof, you are, we can't hear you. Prof, you are on mute. We can't hear you. You'll have to unmute yourself, sir.
My apologies. I'll start that one again.
Yeah, sure, sir.
Is that, you can hear me now clearly?
Yes, very clearly, sir.
Let's get started again. So I was giving a thank you to the APHS for the invitation to speak on this topic. And also a realisation that 1962, the birth year of the APOA, happens to be my birth year, so there's a coincidence. Okay, we're talking about total hip arthroplasty and arthrodesed hips, the challenges and principles. And before we start going down this pathway, the real question is it worth it? Is it worth taking down a pain-free hip, even though it's not a joint, converting it to a hip arthroplasty? What is the upside? What is the downside? And I thought I'd start really with this systematic review by Warrigue and co. They looked at 27 papers, 1,100 hips in all. The mean duration of the arthrodesis was 27 years or more. The mean age at conversion was 52 years with a follow-up of at least 9 years. Note the Harris hip score improved from 58 to 80 overall, and the overall survivorship was 88%. Yes, they had some complications, 13% with the abductor mechanism, and that's an issue to discuss throughout this whole webinar. 6% loosening, 5% infection, some nerve injury in particular, nothing else that's outstanding. So really the answer to that question is yes, it is worth it. There are technical aspects, it is challenging, so we do need to get it right. But why do we fuse in the first place? Hip arthrodesis offered to the young patient if done well, can actually relieve pain, allow a very active lifestyle and allowing manual labour, and facilitate later conversion to total hip arthroplasty when needed. If it's executed well, poor outcomes can be minimised by appropriate patient selection, good surgical technique, correct hip positioning, 20 degrees of flexion, neutral abduction, 5 degrees of external rotation, and an acceptable leg length discrepancy of 2 centimetres of shortening, but no more. And you've got to remember that when you're going to convert it back to a total hip replacement. The causes of hip ankylosis and arthrodesis, this paper by Selectus looked at the conversion of hip fusion to hip arthroplasty in 40 hips, and you can see here the variety of pathologies that may have preceded the fused hip, whether it's sepsis in a quarter of the patient, post-traumatic, early osteoarthritis presenting at an early age where we offered them an ankylosis or an arthrodesis, rheumatoid arthritis, ankylosing spondylitis in 12.5%, and early dysplasia. So there's a range of pathologies that lead to fusion. The downsides of fusion, however, is that there's perspectives of patients such as an altered gait pattern. They can walk long distances, but it is quite abnormal, and ultimately this will have an impact on other parts of the body. There's no difficulties with childbirth that have been reported, some impairment with sexual activity, and of course it's hard to put on shoes and socks and other domestic chores. But this is the real risk of fusion, and this is the reason people will actually present to you for a takedown later on. That is the risk to the contralateral hip. Sophie reported 22.5% had progression of osteoarthritis. The risk to the same side knee, and Haj reported 65% developed osteoarthritis, plus rotary instability over the next 20 years after a fusion. But ultimately, the worst one, according to Sponsella, is the risk to lumbar spine, with 61% developing quite substantial and intractable back pain. So these are the three main indications that patients may present to you to take down a pain-free hip and convert it to a total hip arthroplasty: low back pain, ipsilateral knee pain, and contralateral hip pain. And using that as an example, I'm going to present one of two clinical scenarios. The first one, a 25-year-old lady who presented to me, she had a left hip arthrodesis post-Perthes at the age of 12. She presented with low back pain, wanting takedown of her pain-free arthrodesis. You can see the x-rays here on the left side with a complete fusion, evidence of Perthes on the contralateral side, but with minimal symptoms at this point in time. You can see the position of the pelvis consistent with the fixed flexion deformity secondary to the arthrodesis. After extensive discussion because of her age group, she was in sound mind to take down an arthrodesis converted to a hip arthroplasty. You can see from the templating here, the size of the acetabular components can be small. It's a small size femoral component. We're dealing with a smaller set of anatomy. However, this is very doable. The first osteotomy needs to be above the lesser trochanter by about 5 to 10 millimeters, and we'll go into technique later, and I'm sure this will be tackled by many of the other speakers. But it's to be noted that a second osteotomy, also at the confluence of where the femoral head meets the acetabulum, makes the surgical technique much more simpler if you can extract a segment of bone before you mobilize the femur. This was converted to a total hip arthroplasty. At the time, this was a cementless ABG2, giving a very good outcome. She was seen 10 years later and continued to have a good outcome. And at that time, she presented with pain in the contralateral hip from progressive arthritis, proceeded to a summit pinnacle on that side, and still had good function on the left side where she had the takedown. So this is a successful outcome for this patient, and she's now about 15 years. Hip arthrodesis, therefore, taking a hip that's fused or arthrodesed can develop chronic back pain, ipsilateral knee pain, and this is a reason for presentation and the request to take down the arthrodesis. However, other things need to be kept in mind. This young lad who actually had a fractured neck of femur, he's an islander weighing 100 kilos at the age of 13, went on to very severe chondrolysis and required an arthrodesis with a Marta plate. Now, this is through an anterior femoral approach. And one of the problems here is hardware in situ. And the last case I showed was an easy takedown, but this would be complex because you'd have to remove any of the hardware before proceeding. Other hardware is a Cobra plate, and you've got to keep that in mind. This is put in from a posterolateral approach. And when you see this, you've got to think what's happened to the abductor mechanism, and that needs to be explored a little bit further before you take down the arthrodesis, because that may be compromised and may compromise the actual outcome of the procedure. So my second clinical case is this 60-year-old gentleman. He presented with back pain, requesting a total hip arthroplasty so as to regain motion in his right hip after 50 years of fusion. He wanted to regain better mobility and better function. He sought advice from quite a number of colleagues and turned down, and then presented to me wishing to have surgery performed. He had poor proximal femoral morphology, as you can see here. The anatomical landmarks are difficult to see, and in the lateral projection, the confluence between the femur and the pelvis doesn't show much in ways of distinction and would make it difficult to identify the area where you may make your first osteotomy. Nevertheless, this is an indication for good history taking, early exploration, and other investigations. But the real question is, should you take down an arthrodesis and convert it to a total hip arthroplasty? And what should be performed preoperatively to assess if surgery is a reasonable option? Take an extensive history of what led to the fusion in the first place if it's not ankylosing spondylitis. Was there a septic process? And if there was, is there residual sepsis? And you may carry out a few investigations to determine that. Look at the scars and sinuses in the area. Take an ESR and CRP to make sure that they are in the normal range. Look at previous surgical approaches and incisions in the area, and think about potential damage to the abductor mechanism. Do a clinical assessment of abductor contraction, but I find this very difficult. You may use an EMG. I don't find this very useful. An MRI assessment, however, is more useful, showing the muscle signal and whether there's fatty degeneration in the abductors. Look at the bone quality, particularly the femur and the acetabulum. CT scans can be very useful here, particularly with 3D reconstructions, and I'll demonstrate that. Bone morphology and templating for the size of the implants. But critically, patient compliance is a big factor here when you take down an arthrodesis and convert it to a hip replacement. Is the patient capable of complying with post-operative instructions, understanding of the risks and complications, particularly the risk of dislocation and the persistence potentially of an abductor limp or Trendelenburg gait? So potentially you're taking a pain-free, stable hip area and leaving a painful or unstable hip replacement. That realistic check has to be discussed with the patient. In this circumstance, we did do CT imaging. You can see on the anterior aspect, the morphology is very poor to identify, and this is where you might utilize intraoperative imaging to assist with the area of the osteotomy. On the posterior side, you can define the landmarks a little bit clearer, so you can work out where your initial osteotomy is, the second osteotomy, take out that segment before you mobilize the femur. I use a posterolateral approach, but equally you can use an anterolateral or transtrochanteric, and I believe this will be discussed by our other noted speakers. Expose the femoral neck, take a segment of bone of at least 1.5 centimetres thick, proximal to the lesser trochanter. Use the image intensifier intraoperatively if needed for the position of the osteotomy, and also during reaming of the acetabular component if you're not sure of your landmarks before you ream too much. Intercalary resection will certainly facilitate mobilization of the femur anteriorly and give access to the whole acetabulum for exposure. Ream the acetabulum carefully, as these people are usually osteopenic and the bone is soft. I place a Hohmann retractor in the obturator foramen as a guide for positioning of the cup placement. A 2mm drill bit can be used to sort of depth the gauge if you're uncertain of the bone quality when you're reaming. Tend to increase the version of your cup to improve stability, or consider the use of a dual mobility cup. And this will certainly come down to the quality of your abductors as to whether you use a constrained cup or not. Femoral broaching depends on the selected implant, and consider long stems if the morphology of the proximal femur allows this. And certainly here, I used a pinnacle cup with an SROM sleeve and a longer stem to gain fixation into that proximal femur, which was certainly not of normal morphology. This patient had a good outcome at 6 weeks, and certainly at 6 months he was stable, but he was still walking with a walking stick. His abductors were average. They will recover over time to some extent, but at 5 years he's still using a stick for balance, but happy with the outcome. His back pain has certainly improved substantially, and his scores are very good. So when we take a look at a couple of papers, such as this by Sartek and Abhay Elhence, they looked at 27 fused hips taken down to a total hip arthroplasty. The causes are, as explained before, they used a posterolateral approach with II. 18 of these were cementless, and a follow-up was reasonable at 8 years average. 96% of the implants survived. 25% 25 patients were satisfied. There were no dislocations, but the Trendelenburg remained positive in 30%. And this is part of the discussion with the patient in the preoperative phase. This is like a review paper by Whitehouse and Duncan. It's a very good review paper if someone's looking for one. Fusion to THA conversion are not frequent operations. The period of recovery is longer than the primary total hip and can be up to 3 years in some circumstances. Abductor functional recovery can take up to 2 years. Walking aids may still be required in 20 to 60%. All patients report good to excellent relief of back pain symptoms, and this is where you should consider it. And the 10-year survivorship is somewhere between 74 to 96% across the publications. This is the last paper I want to show you because this is about ankylosing spondylitis. And the question here from Zonki Jiao from Chengdu is whether you should do bilateral or bilateral sequential total hips when patients present with ankylosing spondylitis on both sides. And here they've compared 22 bilateral simultaneous versus 24 bilateral sequential. There were no differences between the groups. Both achieved a good outcome. So this paper really supports that if you have the right patient at the right time, you can offer bilateral simultaneous total hip arthroplasties and still expect a good outcome for these patients. So in conclusion, takedown arthrodesis to a THA is not a frequent operation that we will do. It needs to be familiar with the techniques, have clear goals and indications to be discussed with the patient. This is very important. Make the patient's expectations realistic despite the good outcomes in publications. Preoperative templating for landmarks married with intraoperative use of fluoro assists good implant positioning. Expect good outcomes in well-selected patients. Thank you for your attention and invite you all to join us in Bali for the meeting of APAS on the 24th of August. Thank you, Abhay.
Thank you so much, Prof. Lovely talk and great exposition of a very difficult topic. We have a question for you, which says that how do you do an assessment of the abductor dysfunction in an ankylosed hip?
So, as I sort of covered that, with a patient lying on their side, they obviously can't abduct the leg, but they can make an attempt to abduct, and I'll feel to see if there's any contraction of the abductor mechanism during that time. I don't use an EMG, but that's one mechanism you could use to give you some feedback, but I do an MRI on these patients to see if the abductor mechanisms if the gluteus medius and gluteus minimus are showing fatty change or whether they look normal in terms of signal. If the patient has had extensive surgery from a posterior approach, I'd be very concerned about the abductor mechanism. If it's a spontaneous ankylosis, then the abductor mechanism is likely to be intact and likely to be rehabilitatable over time.
Great.
Raj Kumar?
Dr. Raj, you have a question, sir.
Just continuation to that question about the abductors. Can I answer one point here, Abhay?
Sure,
Please go ahead.
sure, please.
Yeah. So the thing is here, we have to look at it in two different entities. One is the spontaneous fusion and one is the fusion which has been done by the surgeon. So in a spontaneous fusion, you need not worry about the abductors, whether to do an MRI or EMG. It is only if you take down the fusion, automatically everything falls in place, and most of the time the abductors are intact. The fusions which are made by the surgeons are the one which we need to worry about, the abductors, where the abductors are either it is all damaged or it is goes disused and it is goes for wasting and inactivity. So if it is a spontaneous fusion, we need not worry.
Thanks, Raj. So we'll move ahead. And unfortunately, Mez has had to attend to an emergency surgery, so he will not be with us. And I'm just going to send a recorded talk, which I'm going to share with the audience. So Dr. Mehul Acharya is at Bristol and is a prolific pelvic acetabular and a hip and knee surgeon. And I'm going to share his talk with us on spinopelvic balance in total hepatoplasty in ankylosed hips. So that's Mehul for us.
Thank you very much for inviting me to the Asia Pacific Hip Society meeting to speak about spinopelvic consideration.
Sir, hello.
Yeah, we cannot hear.
Yes, and even it's not moving. Slides are not moving.
Abhay, can you reload and restart, please?
I'll do that, sir. Give me a minute, please.
Yeah, take your time.
Am I visible now? Can you see the screen?
I can see this.
Yeah, so sir, can you just let me know if you can hear me?
Thank you very much for inviting me to the Asia Pacific Hip Society meeting to speak about spinopelvic considerations in a fused hip. We'll spend the next 10 to 15 minutes speaking about pelvic tilt, sagittal balance, and how pelvic tilt and sagittal balance affects acetabular component placement, the relationship between the spine and the pelvis and its implications in hip stability. We'll talk a little bit about the at-risk group, and then we'll summarize. So if we look at revision rates in modern total hip arthroplasty in comparison to non-cross-linked polyethylene and cross-linked polyethylene, we see that over a period of 15-16 years, there's a 94% survival rate for highly cross-linked polyethylene. If we look at why things fail, so 6% of these arthroplasties fail over that 16-year period, and the most common modes of failure due to dislocation, fracture, infection, loosening. So is there, or are there, a group of revisions that can possibly be avoided? Well, the answer to this is obviously yes. And so if we look at this in a little bit more detail, 50% of revisions are avoidable, and these are mainly due to poor component placement, poor stem choice, other reasons such as fracture, loosening, leg length discrepancy. So the rest of this talk will concentrate on trying to understand and improve cup placement in fused hips. So we all know this paper. This is a historical paper, Lewinek's paper, looking at the safe zone for a total hip arthroplasty. And it's the 17th most referenced paper in arthroplasty literature. And this paper shows that if you put your cup in a position of between 30 and 50 degrees of inclination and between 5 and 25 degrees of anteversion, this is a safe zone. Okay. But it's important when you look at this paper that actually a third of the dislocators were within this safe zone. If we look at this paper here from the Mayo Clinic, 10,000 hip arthroplasties and 58% of the dislocations were again in Lewinek's safe zone. So the safe zone may not be safe. And so this article here looked at the Lewinix safe zone and said or suggested that this maybe should be abandoned in favour of a functional safe zone. So what's a functional safe zone? Well, this is a safe zone for each particular patient which considers their spinal pelvic mobility. And this is on an individualised basis. So this patient here has their own functional safe zone. This patient here has their own and different safe zone. And this third patient here has a very different individualized functional safe zone. And so why is it important to consider spinopelvic mobility? Well, we all know that the spine and pelvis are interrelated, and the spine can drive the pelvis into a functionally abnormal position that we don't really appreciate on routine x-rays. So if we look at this, the middle diagram, we see that there is a neutral pelvic tilt, and we see that the cup position with a neutral pelvic tilt is 40 degrees of inclination, 20 degrees of anteversion. If we then consider the diagram here on the right of the image, we see that the pelvis has been tilted back by 13 degrees, and if the pelvis is tilted posteriorly, it makes the cup appear in a more anteverted and a greater inclination cup position. If we tilt the pelvis anteriorly, we see that the cup appears to be in a closed position with less anteversion. And so we can appreciate this schematically here. So if we think about the image on the right, look at what happens in extension. So in extension, as the pelvis tilts posteriorly, you see that the hip is at risk of dislocating anteriorly. So there's a problem in hip extension when the pelvis tilts posteriorly. So what happens when the pelvis tilts anteriorly? Well, when the pelvis tilts anteriorly, this is problematic in flexion. You can see that the hip is exposed posteriorly and may well predispose the patient to dislocation. So let's see examples of this then. So this is patient number 1. This is the patients with a supine AP pelvic x-ray. And this is the same patient when they stand up. You can see that the position of their pelvis has changed. You can see that the cup appears more open and more anteverted. And this may well predispose the patient to an anterior dislocation when they stand up in extension. Example number 2. So this is a patient who is standing up, weight bearing, and this is an AP of their pelvis and a lateral of their spine and pelvis. And you see that the component position looks pretty good. Same patient in the extreme flexed seated position. And you see what happens to the hip. In deep flexion, the hip is exposed posteriorly and potentially exposes the patient to dislocation posteriorly. And so when we look at the relationship between the spine and the pelvis, the x-rays that are required are these: a standing lateral of the spine and the pelvis, and a seated lateral in the fully flexed position. So the one on the right here. And why are these x-rays required, and why the seated position? Well, we know that in the full flexed position, the hip may well dislocate, and hence we want to see the extremes of position. And secondly, we want to look at the mobility and the flexibility of the lumbar spine, as this is important. So what to measure? Well, these are the parameters to measure. And we won't go over how to measure all of these today, but we'll talk about the importance of these. So the pelvic tilt, and this is the pelvic tilt, and we've already talked about how the pelvis can tilt anteriorly or posteriorly, the sacral slope, the lumbar lordosis, the pelvic incidence, and then the spinopelvic tilt. And the sacral slope plus the spinopelvic tilt equals the pelvic incidence. And so who's at risk? Well, this article here by Pierpont and Langston looked at over 4,000 patients with end-stage arthritis. And what they found is that the patients who are at risk of an increased sagittal pelvic motion were those who had spinal stiffness or had reduced lumbar flexion. This paper here looked at over 1,000 consecutive total hip arthroplasties from hospital special surgery, and they had a 1% dislocation rate. Again, in their paper, those that had a dislocation had significantly less spinal flexion, less than 20 degrees. 600,000 total hip arthroplasties from the database. These looked at patients who had had spinal fusions or spinal instrumentation, and the control group with no instrumentation had a 2% dislocation rate. Those with less than 3 levels of spinal fusion had a 4% dislocation rate. Those with greater than 3 levels fused had an 8% dislocation rate. This article here, looking at 139 total hip arthroplasties in just over 100 patients, again, they looked at spinal deformity and they defined it as a mismatch between the pelvic incidence and the lumbar lordosis. And what they found is that patients who had a spinal deformity had a dislocation rate of 8% compared to the general control group of 1.5%. And so what is sagittal balance and why is it important? Well, we've talked about the pelvic incidence, and the pelvic incidence is a fixed parameter that describes the AP width of the pelvis. Okay. And for an individual to be balanced in the sagittal plane, the lumbar lordosis must be very similar to their pelvic incidence. If there's a mismatch between the lumbar lordosis and the pelvic incidence, then certain things can occur. So if you've got a mismatch and you've got a pelvic incidence minus the lumbar lordosis of less than minus 10 degrees, then their spine is usually hyperlordotic. If there's a difference which is greater than 10 degrees between these two parameters, there's sagittal spinal deformity or imbalance. And if there's an increased difference between these two parameters, so greater than 20 degrees mismatch, then there's severe sagittal spinal deformity. And this has an 8% dislocation rate, much higher than the control group. And so it's important to understand that just because a spine is fused doesn't mean that it is just this group of patients who has a limited spinal motion and an increased pelvic mobility. If you have degenerate discs, these act in the same way as a potential instrumented fusion, and they can have the same effect on the spine, limiting spinal movement and increasing pelvic motion. So if we look at the at-risk group of spinal mobility and those predisposing to dislocations, these are the 3 parameters which are really quite important. So those patients that have a limited lumbar flexion of less than 20 degrees, those that have a large posterior pelvic tilt, where the pelvis tilts posteriorly more than minus 10 degrees, and those with severe sagittal spinal deformity, so the pelvic incidence minus the lumbar lordosis mismatch of greater than 20 degrees. And if we look at the cohort, then actually approximately 17% of patients demonstrate one or more of these abnormal characteristics. And if we put all of those characteristics together, then we find that this equates to about 1% of patients. 33 of these patients with these parameters are aged over 75. So in conclusion, we should just think a little bit about cup placement. We should think about the relationship between the spine and the pelvis. We should understand that the safe zone may not be equal in everyone. It's important to understand that there is a relationship between cup orientation and an individual's spinopelvic mobility, and this must be appreciated. And this is very important in patients with fused hips. And it's recommended that actually, if you want to look at the spinopelvic relationship and the mobility, then a preoperative standing X-ray of the spine and the pelvis and a flexed seated X-ray, looking at those various parameters we've looked at, may well be very, very helpful. And then what do you do if patients have these at-risks parameters? Well, it may well be that you need to consider bearings with increased stability. So if you have someone with limited lumbar flexion of less than 20 degrees, a large posterior pelvic tilt of less than minus 10 degrees, and a severe sagittal spinal deformity, you may well think, well, actually, I might use a bigger head, a 36 millimeter head. I might go and use a dual mobility, or I might consider other bearings. Thank you very much.
So, great talk from Mehul. And getting back to the presentation, can I just quickly walk across the board and ask a couple of our faculty members, starting with Rami, Professor Rajesh Malhotra sir, Shahid sir, and Dr. Rajeev sir. Very quickly, could you just walk us through what standard preoperative protocols do you follow when you want to assess and evaluate the patient radiologically who comes with an ankylosed hip for a convergent arthroplasty? Can we start with Professor Rami, sir?
Yeah, thanks, Abhay. Look, it's not just ankylosed hips. Actually, for all hips, I do use a system called the OPS system, which incorporates those special X-rays in extension seated and flex seated, and it goes through an algorithm and then gives me actually a software program that shows me through flexion to extension the position of the femoral head with a prosthesis in situ and the risk of dislocation through flexion to extension. So the OPS system is actually a good system if you want to incorporate this sort of technology, getting the standard X-rays on the patient in those three positions that was quite well described. It also is a templating system for templating the acetabular component, the femoral component, but it marries up that if you do have significant changes in pelvic tilt or a change in mismatch, then it gives you opportunity preoperatively to determine whether you should have a DM cup on standby. It's not something I use routinely. I will use a standard 36 millimeter head in just about all patients who have an acetabular component of 50 millimeters or more. But in those patients where you see that there is a mismatch or a significant change in pelvic tilt based on those X-rays, then I'll have a DM cup on standby.
Thank you, Professor Rami. Dr. Malhotra, sir, what would your practice incorporate in terms of how you will assess these patients?
We do exactly the same thing. We take two X-rays, the standing lateral and the deep forward bending deep flexed lateral film while seated, and we have the advantage of having EOS. So all these complex spinopelvic, particularly the Ankylosed patients, we assess by EOS, and that helps our spine surgeon also plan better. So all this pathological stiffness where the spine is completely stiff, either surgically or because of Angst-Pond, we would like to go for dual mobility, and my stem choice is SROM. So while we make adjustments for the component placement according to the parameters which we measure, they still help us keep the instability at bay.
Thank you, sir. Professor
Abhay,
Shahid, sir, would you do anything different?
Can I just make a comment first, Abhay?
Yeah, sure.
And that is, just to clarify for the listeners, is that, this is a standard approach we use in all patients with standard arthritis. But if you've got a fused hip, you can't use this technology because obviously there's no movement at the hip joint. So even though you go from the standing to the fully flexed seated, if you've got a fused hip, that movement isn't actually available to you. So as Rajesh said, we'd have a dual mobility probably as a routine in those patients. You can do the templating from the software program, but you can't go through that process of seeing their stability through the range because the pelvis dynamics is changed by the fusion.
Sure. Professor Shahid, sir, anything different you do here, sir?
Yes. I don't have the luxury of using this software, so I rely on conventional pelvic X-ray and a CT scan. My threshold for using dual mobility is very low in these cases to avoid dislocation because the abductor mechanism are damaged, and that's what we do.
Dr. Rajeev, sir?
Almost the same what we have discussed already, excepting that I am very careful in patients who have a totally fused spine. There is no movement, or the fusion is at more than 3 levels. Now there it is very important to assess the combined antiversion. Otherwise, most of the things are what we have already discussed.
Okay, so bordering on wasting a little time, may I just quickly get Nikhil, Zhang, and Professor Rami again onto this, and Raj onto this, and ask you people that what are the most important pelvic parameters that you want to work with when you are assessing an ankylosed hip on X-rays? So can I start with Zhang first? So when you're assessing the ankylosed hip, what are the most important radiological parameters? So the spinopelvic alignment, the anterior pelvic tilt, and the sacral slope. So which one of these do you work with the most, and what is your workhorse in terms of how you will plan?
Okay, so for me, I think although we have so many imaging ways to assess the acetabular orientations, I think, but a sad fact is that sometimes the patients is not willing to incorporate sometimes to do so many preoperative imaging at first, and then I think due to the nature of the disease, the patient's positioning is always not very ideal or suitable for some to get a decent X-ray, or you can do a decent mirroring. So we now in our place we start to do ESOs, but and other ways to assess the to hopefully to get a right assessment of the orientation of the hip of the cup. But I think sometimes it's very important to us to go back to use some old fashions like traditional physical examinations to test the range of motions of the spine, and also the hip, and the nature of total hip is actually very forgiving. So it's not really. I think it's clinically we should be more. I think we should be more.
So would it be fair to say that the parameters that you measure on X-rays and on these fancy investigations are just a guide, and you go by basically how you feel once you've gone through the osteotomy on the?
I think intraoperatively, after you put in the trial and And then intraoperative movement, it's a very reliable parameter to test the stability. I think it's like the orientations, like the positioning is all about the stability or range of motion. So I think I would do that. Just if you do enough.
Great points there, Zian. Dr. Raj, do you use these pelvic parameters in your practice?
Yeah.
And Nikhil, do you?
Yeah.
I'll let Rajeev go first.
Okay. Thanks. Abhay, definitely we now started using these parameters, and a lot of insights and a lot of information coming out of this. But the two important things which I will consider is, one is in a spontaneous fusion where the opposite side is also involved most of the time due to an ankylosing spondylitis. If it has happened, then we have to see whether which side is an abduction or an adduction. So abduction deformity on which side and adduction deformity on which side, where the pelvic tilt. One is that we have to consider the opposite side, very important. Second thing is whether the spine is fused. If the spine is fused, then we are not going to deal with much of change in the spine after surgery. So most of the time it is the perioperative parameters we have to rely on. But if the spine is not fused, then we have to see whether there is an hyperlordosis or a hypolordosis. Based on that, the pelvic tilt happens and we have to change the orientation. This is the most important thing. But in a non-inflammatory condition, when there is a fusion, that time we have to see if the patient has got an additional pelvic spine pathology, and if the patient is waiting or an impending spinal fusion is going to happen, like the patient needs a spine surgery. That is the case, we have to be very careful, and the most of the time we might need a dual mobility where we anticipate something in the spine later on, and that changes the this thing that is before the THR if the spinal fusion needs to be done. So we have to look at it in two different scenarios, whether a spontaneous fusion case or a non-spontaneous one.
Great, thanks. So you'll individualize to the patient's presentation. Nikhil, very quick word from you before we go forward.
So you're looking at two problems: the stiff spine with an ankylosed hip, where these investigations and these fancy parameters are not really useful at all.
Yep.
And the stiff spine with an arthritic but still mobile hip, where theoretically these special investigations may give you a tool of assessment. What it does not give you is the femoral component positioning. It does not give you the intraoperative feel of the soft tissue tension, and it does not give you what combined anteversion you should make for that particular patient to have a stable hip. So for me, at this point in time, these expensive investigations don't have any relevance to my practice. Clinical examination is more relevant. Intraoperative assessment of stability, which starts from positioning the patient. If your patient positioning is wrong, your pelvic tilt is wrong. And then assessment of combined version using a variety of different techniques to get stability. Because these investigations are not prescriptive at all. And there's no evidence that they have actually reduced the dislocation rate. So using just these clinical parameters, I think my personal dislocation rate on the National Joint Registry is just under 1%. So at the moment, I'm not aware that any of these expensive investigations are clinically proven to improve the instability rate. And I would have one question to the whole faculty, especially Raj. You mentioned that you changed the orientation. Can you elaborate on that? Because I don't make any attempts to change.
Nikhil, can we come back to this question in the Q&A session? Yeah. So as a take home from all of you experienced surgeons, would it be fair to say that the fancy investigations are more like a retrospective guide to patients whom we've had complications for, and their actual indications in terms of stiff spine and mobile hip and stiff spine and arthritic hip are more evolving as per a prescriptive nature of their use? So I guess with what we've heard from all of you, that is what the message for the audience would be.
Right.
Yeah, so moving on, I think we'll take up perioperative considerations, and may I request Professor Amin Chinoy Saab to please share his screen.
Thank you very much. Is it the screen visible now?
It is visible now.
Thank you very much. So I'm Amin Chinoy. I work at the Indus Hospital and Health Network, Karachi in Pakistan. This is the hospital that I work in, and we are actually working on the expansion, which you can just see in the background. At this stage, hopefully in a couple of years' time, it will be about 1,300 bedded hospital. When we talk about the arthrodesis and conversion to arthroplasty, as Rami pointed out, that many patients may be unwilling to accept arthrodesis as a primary treatment option, or they may come and request conversion of an existing arthrodesis to restore motion. As pointed out elegantly by Rami, pain caused by arthritis or other conditions of the spine can increase significantly when sitting with the spine partially flexed because of a fused hip. And patients with a fused hip do have a higher energy expenditure during gait. As pointed out earlier, the history of the initial reason for arthrodesis is important. Patients with prior infection require a thorough evaluation to root out persistence of the infection. Careful assessment of the function of other joints, especially the lumbar spine, should be done, and leg length discrepancy should be measured. Preoperative metal subtraction CT can be helpful in determining the adequacy of bone stock and presence of osteoarthrosis. We've talked about the spinopelvic measurements. In Pakistan, we still do not have that luxury of those systems yet. Evaluation of the abductors may be difficult to evaluate, but in some patients, active contraction of these muscles can be palpated. Examination of the hip with the knee flexed helps differentiate the tensor fasciae lata from the abductor muscles. If the hip has been fused since childhood and the trochanter appears relatively normal, the abductor muscles are probably adequate. If the bone around the hip has been grossly distorted by the disease or by one or more fusion operations, the abductor muscles may be inadequate. It is a technically demanding operation. As pointed out earlier, it needs adequate exposure with maintenance of restoration of the abductor function. If the hardware has not been removed previously, then removal of hardware may be needed, and then one may consider doing it 1 or 2 stage at this stage. Careful identification of bony landmarks to ensure the proper implant positioning. The surgeon has to be familiar with the technique that was used for the hip arthrodesis, because it would influence the exposure need and the need for bone removal, particularly in patients who have had extra articular arthrodesis. The position and exposure, the patients are placed in the lateral decubitus position. As pointed out earlier, because the hip has been fused, either it was a surgical fusion or is because of ankylosing spondylitis, patient may be abducted or adducted, and the tight adductors or abductors may need to be released. Some of these patients do have a flexion deformity, and the straight head of the rectus may require release from the ASIS. The supine position may be used if a direct anterior approach is preferred. The skin incision, however, may be dictated either by the previous incision and the need for hardware removal. If it was a spontaneous arthrodesis such as ankylosing spondylitis and there's no incision present, then maybe a posterior lateral incision may be used. However, personally, I have used lateral hardening approach for all of these patients. So this is one of the patients, as you can see, had a grossly, this was inflection, there was no movement. And these patients really, just difficult to position them on the table. There isn't really much abduction at all. So prepping and then draping in these patients can be quite a challenge. And one can see the degree of flexion deformity and abduction that this patient was in. And one had to really ask the assistant to be careful, because you really don't want to have fractures peroperatively. The trochanteric osteotomy has been talked about in the literature, and it is useful for complete mobilization of the femur, better exposure to minimize component malposition. It is said that it prevents errors in the femoral reaming and it may prevent fractures. In ankylosing spondylitis or previous arthrodisc hips, a femoral neck osteotomy is performed somewhat more proximal than the anticipated final osteotomy. One is actually aiming to take out a biscuit of bone, so 2 parallel osteotomies, and then once that is removed, then one can start identifying the bony landmarks and then ream the acetabulum. Further release of the soft tissues around the proximal femur will improve the exposure. Identification of the inferior aspect of the acetabulum is important, and one may use Shyam to make sure that one is at the inferior aspect of the acetabulum. And this is where a blunt retractor should be placed just beneath the teardrop. So a neck osteotomy here has been performed just prior to reaming the acetabulum, the femoral head and the acetabulum. One has to be prepared when one is converting these, because if on waist implant removal, then one has to make sure which implant, because most of the time these implants have been put in 2 or 3 decades earlier and the armamentarium may not be available. So one has to have metal cutting bars, broken screw extractors, etc., to be able to remove all of these implants. The prosthetic implant selection will depend on the bone quality, both on the femoral side and the acetabular side. Cortical defects or stress risers because of the implant removal or hardware removal may need to be taken into consideration. The amount of deformity in the proximal femur, the patient's age and activity level, surgeon's preferred implant fixation method. And personally, I was using a lot of hip resurfacing arthroplasty in my patients with ankylosing spondylitis till 2011. At this stage, we had to abandon them. So still, I would use a large head, and really, I have a low threshold for using dual mobility cups in these situations. So this is one of the patients who has one side done, is waiting for the second side now. Obviously, this operation is not without its complication. As Rami pointed out, 7% incidence of nerve palsy, trochanteric non-union, heterotopic ossification about 13%. The rate of dislocation in the literature is really not greater than observed after primary hip arthroplasty. Thank you very much for listening, patient listening. These are 2 aerial photographs of the Karachi city center and the beach on the right. Thank you very much.
Thank you so much, sir. Amin, sir, for a fantastic talk. Very difficult situation, and it's extremely important to have all the tools in the toolkit so that we avoid all the complications. Can I have a quick word from you, and then maybe just a quick feedback from Rami as to the non-orthopedic parts of our preparation, perioperative preparation and assessment? How important is the spine to you, and would you want to talk to anesthetists as to how these patients might be?
This is, all part of the workup, and it is very important. What you've got to differentiate is the 2 types of patients, those with ankylosing spondylitis where the spine may be involved, and obviously anesthetic involvement is critical here, appropriate imaging studies of the cervical spine and lumbar spine. How are you going to position the patient on the table? And that's best done at a time and place outside the operating theatre, probably with a pre-operative consultation with the anaesthetist involved to determine the patient's preparation, as opposed to the patient who has an isolated pathology within the hip, either post-traumatic or post-sepsis or an inflammatory arthropathy, where the cervical spine, lumbar spine is quite normal. then it really is just a consultation as to any special needs for positioning. I do use the posterolateral approach, so the patient is in the decubitus position. One thing, however, you need to know is if the hip is fused in an excessive amount of external rotation, you may have difficulty coming from the posterior approach. So that's a circumstance where you may be prepared or have to consider coming from the anterior aspect or a transtrochanteric. So the rotation position of the femur is important. CT imaging does help a lot, as I demonstrated in that particular case, if there is rotational deformities, and also helping you with respect to the sort of bone quality you're going to have in the region. But certainly consultation with the anaesthetist is an important part of that workup.
Dr. Rajeev, sir, a quick add-on or anything additional that you normally would do in such situations?
I agree with Amin and Rami what they explained. I think the most important thing is that the patient needs a good clinical examination. We need to understand that what is the position of the spine and pelvic spinopelvic obliquity. And during surgery, the perioperative consideration, one of the important points for me is that these are very osteoporotic bones. The fixation is one thing on the table. It has to be stable. So a very stable fixation of the cup and the stem, both is very important. And over-reaming of the acetabulum is one of the major issues, and that has to be seen carefully.
Okay, so I have a question in the chat box. It says that would a direct anterior approach be better approach on the hips that are ankylosed and not too much flexion? So before I request maybe the anterior hip surgeons, I know Professor Malhotra sir is one. So before I go to Malhotra sir with this quick question, a very quick yes and no by faculty, starting from Rami, is that do you prefer horses for courses depending upon the position in which your hip is ankylosed to define the choice of approach? Or
Yes.
do you do the approach which works in your hands routinely?
So this is complex surgery in patients you're not going to see very often. So if you're used to the posterior approach, I would argue that you should stick to the posterior approach and not try doing an anterior approach on a complex patient. So if I don't do the direct anterior approach, I have an extremely externally rotated femur, I may consider sending this patient to someone who comes in from the front and maybe consider that as an option. But the ones I've done have all been through a posterior approach and quite satisfactory.
Dr. Shahid, sir? Same approach or horses for courses?
Same approach, always lateral hard hinge approach, always.
Okay, Rajeev, sir?
I prefer the posterolateral approach in almost all the cases, except in some cases that I'll make the same posterolateral approach, and I'll open up from, it's kind of a dual approach. I'll open up anteriorly as well as the trochanteric osteotomy.
So horses for courses, depending upon the situation. So depending upon the case, you'll choose the standard approach or an additional approach.
Some alteration, but I'm not enter approach surgeon, so I don't take the enter approach only.
Okay, sir. Raj?
Yeah.
Quickly, same approach or horses for courses?
No. Same one single approach.
The one that you normally practice.
Anterolateral.
Okay, great. Nikhil, your choice. Would your approach change with the position of the ankylosis, or would you do what works in your hands?
In most cases, you don't need to change anything. I would just do what works in my hands that Rami said, use a posterior approach. But in certain cases with very severe external rotation deformity, through the same approach, you can actually palpate the anterior neck and you can go anteriorly, put your homons there and use that as an additional extension of the posterior approach to perform your cuts under vision, like Pradeep Bhosle from Mumbai has described, the dual hip approach. So in some cases, I would just get benefit or get help from an anterior visualization.
Great. So coming to Dr. Malhotra, sir, who does both anterior posterior extremely well. Sir, how do you take your call on which approach you would use in a given situation?
Abhay, since I know most people use posterior, I'll tell you how I've evolved from posterior to dual approach. And then in cases where it was not possible to put the patient in lateral position, I did the anterior part of the 2-incision MIS to divide the neck in supine position and then put the patient lateral and do posterior approach. But now for last 3 years, I'll do all these only by direct anterior approach, it's a beautiful thing. I think it's ideally suited for bony ankylosis. You don't have to worry about positioning the patient, and above all, you can actually see where you are reaming and where you are putting the cup, because the imaging is really easy compared to the lateral position and the posterior approach. So it's a beautiful approach for bony ankylosis, I believe.
So is that also a guideline from you, sir, to young surgeons, that we need to learn all approaches, including the direct anterior, and one needs to be learning 2 approaches well if you want to do the entire spectrum of hip disorders?
So my mentor, David Morgan, used to tell me that you have to be a circumferential hip surgeon. So hip surgeon must know how to get in from all sides. Although I do agree that direct anterior has a learning curve, but then you must be conversant with all approaches to the hip. For instance, if there's an infected hip, which has been done by anterolateral approach, in a 2-stage, I'll take it out from the anterolateral approach only and not violate another plane of around the hip. So you have to know everything. Yes.
Thank you so much, sir. And moving on, may I request Nikhil to talk us through his case on posterior approach considerations in a fused hip takedown.
Can you see me, Abhay, and hear me?
Yes, we can see and hear very well.
So good morning, everyone from sunny Manchester. The remit of my talk is to describe the posterior approach in ankylosed hips. Now, one of the things I have noted is that the vast majority of discussion today is revolving around ankylosing spondylitis. We have to appreciate that there are other causes why a hip may be very stiff and ankylosed. So what I've done is tried to find those cases which are not typically ankylosing spondylitis. So we'll discuss some post-traumatic problems and some failed cases of surgically attempted arthrodesis. The other reasons may be extensive heterotopic ossification, which is usually post-trauma or where you have head injury, old sepsis, and complications after the treatment of childhood disorders. So this is my first case of as an acetabular non-union leading to ankylosis. This gentleman came to me when he was 68 years old. He had a fracture of the acetabulum almost 4 decades ago. The first attempt at surgery he had was using a lateral incision, and they attempted to do a lateral traction, which I think was prevalent in those days. Unfortunately, the screw broke, as you can see. The second attempt at surgery was through an iliofemoral approach, where they attempted to perform an arthrodesis and also take that screw out. Unfortunately, that was unsuccessful. And then there was a third incision, which was more posterior, which was probably to try and take that screw out. And that unfortunately gave him a sciatic nerve and he had a partial foot drop. So this gentleman had not walked for 44 years and was effectively in a wheelchair. Now, despite the attempted arthrodesis, he was in a lot of pain and basically came seeking for a surgical solution. So my workup for him was to exclude infection. Well, first of all, I tried to check whether he really wanted me to attempt surgery which could make him worse. And one of the surgical options we discussed was to basically accept a girdlestone excision arthroplasty. Because what he also had, which you will see on the x-rays, is a non-union of the acetabulum. So we have a double problem here. We have an ununited acetabulum, which was like a transverse fracture, and we have an attempted arthrodesis with a broken implant, and we have multiple incisions, and we have a foot drop. So quite a complex scenario. These were his incisions. He had leg length inequality, a fixed flexion deformity, a fixed external rotation deformity, and a partial foot drop. So these are his CT scan images, which show the non-union and which also show the metal work. As you can see, it's quite a challenging option. So what are the treatment options for treatment? One of the options is to try and remove that screw, achieve union of the acetabular non-union, and then perform a hip replacement. This can be done in a single stage or it can be done in 2 stages. So the consideration would be what surgical approach would you use and what intraoperative difficulties you might encounter. Extensive counseling about intraoperative complications, neurovascular injury.
Would you like to get the other faculty into on what they will do here? And
yeah,
then we can
I don't
touch
mind
upon what you did. So
I don't mind at all.
You can request 1 or 2 colleagues to just opine on what they would do.
So I don't know if anyone is a pelvic and acetabular surgeon here. Dr. Malhotra mentioned a circumferential hip surgeon. I think doing pelvis and acetabulum would probably be part of being circumferential. So any comments from anyone?
So Raj, can I get you onto this? How would you approach this particular case? Raj, are you there? Shahid, sir?
I'm happy to make
Rami,
some comments here.
Fine. Sure.
So look, obviously, this is a very complex case in someone who hasn't walked for 4 decades, so that bone's not going to be great. The other thing I'd be concerned about is a sciatic nerve injury from previous surgical intervention, which means that what remains of the sciatic nerve, and I don't know what function is left, may be matted down in scar tissue. So if we come from a posterior approach, that's going to be at risk as well. But obviously, we're showing this because we're going to do some surgery, and I've seen a surgical slide. So let's just take it that we've had thorough discussion and the decision's been made that surgery is going to happen here. The one advantage here is there's a rather large femoral offset. So there's plenty of neck that you can see on the plain X-ray here, which is actually to our advantage as opposed to a short neck, which means you'll be able to delineate the anatomy once you come in from a posterior approach. And I would use a posterior approach here. Obviously, you've ruled out infection. I'm not going to go into those base details. So let's assume this is aseptic. I would come in from a posterior approach. I'd make my osteotomy just above the lesser trochanter here and take another, say, 1.5 to 2 centimeters above that and take that whole segment out. That would then expose part of the acetabulum. We've noted that there's a defect there, but I'd be going for a cup cage construct in the reconstruction of that acetabulum. Those screws will have to be found, over-reamed or trephined and removed, and then a thorough curettage of the area. I'd probably use a very large porous cup, so I'd ream into it carefully. It is going to be very soft and osteopenic, but I'd use a multi-hole porous cup with dome screws through the cup, go through into the ileum and potentially down into the pubis, and I'd then lay a cage over that and use a cemented polyethylene insert, maybe a dual mobility, cemented into the cage. And that's probably my approach if I was to tackle it with a surgical procedure, but there'd have to be a lot of discussion, investigations beforehand, Nikhil, to make sure he's actually an appropriate candidate.
Great. Nikhil, can we go ahead with your...
Very nice comments, Rami. And I particularly like the comment where you mentioned a cemented dual mobility. You know, if I don't get the smell of cement at Wrightington, I get a splitting headache. So I do need to smell cement. So my tactic was similar, but biomechanically, I believe that fixing the acetabulum with the help of plates is much more stable than fixing it using a cage to bridge the discontinuity between the ileum and the ischium. And I have a big series of about 40 cases of 1-stage and 2-stage fixation of the discontinuity with column plates and then performing a hip replacement. So my tactic was similar to yours. I did an osteotomy carefully to mobilize the hip joint and to gently deliver the femur out. Then the head came out. Then you can see that osteotome basically freshening the non-union. Now, what happens in an acetabular non-union is the inferior fragment goes into external rotation and often medial translation. So you have to derotate the columns before you can make that acetabulum whole again, so you can put something in. And for that, you have to do what is called as an ischial spine osteotomy. Then you can derotate the column, freshen it up, impaction bone grafting. And then, like you said, using trephinds and fine flexible osteotomes, I was able to get that broken screw out. Then I fixed the columns with the help of plates and screws, performed impaction grafting, and it was a very solid construct. So I was quite happy to go ahead with a cemented cup rather than with an ultra porous cup with extra screws. That was the early post-operative X-ray using plates and screws. And Abhay will remember that in 2014, when we met at Hyderabad, I showed him the 4-year follow-up. And I think he's due to come again in a couple of months, but that was the 12-year follow-up with a well-healed acetabulum, no problems with the metalwork, a healed non-union. Now, this gentleman walked for the first time after 4 years, and every 2 years, he sends me photographs of him walking, usually on a cruise ship. So I don't know what's happened during the pandemic. So that was the first case. The second case was a humbling experience for me. This lady has very severe learning disability because of neurological issues during childbirth and developmental problems. And she has gradually developed quite severe osteoarthritis with acetabular erosion, protrusio, leading to secondary ankylosis. Her ambulatory ability was just a few steps. So usually from bed to chair, chair to bed, and a couple of steps within her care home with the help of a walker frame and with the help of 2 other assistants. But she was basically in agony, and the only way she can express pain is making verbal sounds because she does not have speech. So we have a process at Wrightington where we do a second opinion for these patients. We do a very thorough MDT discussion. We have an adult safeguarding department that gets involved, and we have what is called as a best interest meeting where everyone who is involved in the care meets and decides what to do. And the decision was to try and perform a hip replacement on one side and see how she does. She was extremely osteopenic, and despite my best precautions, a very meticulous release of all the soft tissues and an attempt to do what is called as a napkin ring osteotomy, she unfortunately had a fracture during surgery. So this was my preoperative plan using a cemented construct, and I was planning to do a cemented dual mobility because her mobility was quite poor. So I had this spiral fracture in the midshaft of the femur, which I detected. I fixed it, and then as I made my second attempt to bring the hip out gently, I had a second fracture below the first plate. She was that osteoporotic, just literally lifting up the leg led to a second fracture. So then I had to remove the first plate and use a much longer plate all the way down to the knee, and then hold the femur with the help of some hay groves, and then proceed with a napkin ring osteotomy. This time, thankfully, I did not have a third fracture. The femur came out, and I was able to complete the operation. So then the discussion was whether I should go for a long stem or keep it like a primary stem. And because I had bypassed nearly the whole osteopenic femur with the help of a long plate, I stuck with a primary C-stem and a cemented dual mobility. The acetabular reconstruction was performed with the help of impaction grafting, which is one of my favorite techniques of acetabular reconstruction in a contained defect. And I used an additional anterior strut to strengthen the femur. So I have published my data on strut grafts, about 20 cases, and anterior struts do work extremely well in this scenario. And that is the follow-up X-ray at around 12 to 14 months. She has good relief of pain on that side, and it is quite a delight to see her when she comes for follow-up, because after many, many years, people have seen a smile on her face. And that's the only way she can tell you that she is actually happy with it. I have time for a third. If you have time for a third case, I'll show this, Abhay. Otherwise, I'm happy to stop. Abhay?
I have a question, Nikhil. Are
Yeah,
you going to do the other side?
Yes, so I've offered to do the other side, but what the nursing home staff tell me that after this side was done, she has basically stopped verbalizing or screaming or shouting. So they think that she does not have much pain level. So I'm going to watch it and see what happens. And when I ask her whether she wants the other side doing, she understands. And now there is a trusting relationship because she recognizes my face, having seen her so many times. And her response is that she just does that. So I think she'll tell me when she wants the other side, and I'll wait for that.
So may I just request the house, the faculty's opinion on what they would do in a given situation, and maybe just keep the third case for the panel in case we have time.
Yeah, sure, Abhay.
So, Dr. Rami, would you do something differently here?
Look, it's very difficult to know exactly the forces applied, observing what has happened on 2 occasions with these shaft fractures. It's very unusual. I would always do a similar thing, attempt to dislocate the hip, but if I'm struggling, I'll make an in situ osteotomy just to facilitate mobilization of the femur and then take the head out separately. But, I'm not sure the force applied there, Nikhil, as to whether you feel it was the registrar pushing too hard, or was it really a case of...
The way it happened is I actually could see just a sliver of the neck, and I was getting ready for an in situ osteotomy, and I was holding the leg myself, which I then gave to my limb holder. And as I was making the osteotomy, the femur fractured. So literally the forces applied were negligible. I'm sure there must have been some very subtle rotational element to cause a fracture, but it was one femur that was crumbling in your hands. When I tried to fix the plate in, even if I applied the Hay Grove, the femur was crumbling. So this has happened despite me being aware of it, talking about it, telling my assistants what I'm doing, and it happens in front of me.
And I guess that was the emphasis of my question. Having had that experience with this left side, is that the reason you've left the right side alone? Because obviously you don't want to go down that pathway again, and it's possible the same thing may happen on the contralateral side.
Well, the thing is, when you work in a tertiary center, you have to accept the good with the bad. And when you take on complex cases, complications are unfortunately sometimes unavoidable. So one experience will not dissuade me from operating, but I've left it alone because the patient does not need it at this point in time. When she needs it, my considerations will be whether I use a short stem and a prophylactic plate before the femur fractures, or whether I try and deliver the femur out without a fracture and then use a short a primary stem and nevertheless put a prophylactic plate anyway, so she doesn't fracture in bed when the physiotherapists are moving her. Because I've seen that happen as well sometimes.
Nikhil, can I ask, what about the bone density, and has she been investigated and treated? And for example, before embarking on the right side, treating her osteoporosis actively might reduce the chances of intraoperative fracture.
No, the osteoporosis has not been treated, although it has been investigated. So we leave that in the hands of the rheumatologists to perform a risk-benefit analysis of giving them bisphosphonates or any other treatment. She was on calcium vitamin D, but not bisphosphonates.
There is a question in the chat box before we move on to the next case. Any role of preoperative denosumab or bisphosphonates in such severe osteoporotic patients? Would anybody use biologics here in the faculty?
We have rheumatologists, and obviously we have all options of osteoporosis from bisphosphonate. And in very severe osteoporotic patient, we use teriparatide with an excellent result. Bisphosphonate take a long time to act. They take years, but injection teriparatide, it takes months, and we have seen wonderful result.
Zian, can I get you onto this? What would your take be here? Dr. Zian, are you there?
Abhay, can I ask a question?
Yeah, sure, sir.
Just wanted the comment of the faculty of the house on the use of this short stem. I was wondering when I was seeing this presentation, and I was really wondering what sort of a stem would Nikhil use, and once this has been put in, I really would want to hear what the faculty has to say about it.
Maybe take two quick comments, please. May I request Dr. Rajeev sir and Dr. Malhotra sir for their opinion on this?
Well, in my hands, short stem, I would prefer not the Proxima kind of a short stem, but a corail stem. And I don't use much of the cemented stem. In my hands, probably in this case, corail stem will be right. And one of the case, what Nikhil has very rightly explained, that how weak these bones are. We did just about 3 days back a patient who had a fracture on the table, and there we used the restoration stem very well. But I think I agree that in this kind of a situation, a long plate is a good option.
Dr. Malhotra, sir?
These are our patients are mostly young patients, so my first choice is a short stem. If the patient is folding and the patient is young, and whenever there's a poor bone quality, we do a prophylactic wiring, and that has kept us away from splitting the femur when we are doing this. But the short stem I use is Meta, which is neck preserving, and that is actually we have got very good results even in poor bone quality. But we have to avoid the fracture intraoperatively by prophylactic wiring.
Thank you so much, sir. And Nikhil, may I just request that for constraints of time, can we move on?
Yeah, I'm happy to stop. You want me to stop sharing?
Yeah, I think we can move on. And the next speaker on the would be our a fused hip takedown by Raj. And he does an anterolateral exposure.
Yeah. Just before starting, one small question to Nikhil. Can I ask?
Sure, please.
Nikhil, just this is a question about the cemented dual mobility. We know that the cemented dual mobility doesn't do well, unlike the uncemented ones. So in this age group, I know the situation has compelled you to do that. But what is the take on cemented dual mobility in NHS?
Paradoxically, we have found that the uncemented dual mobilities don't do very well because you can't really put screws into them unless you're using a specific brand where you can put screws into them.
Yeah.
So all of us use cemented dual mobility, and now we have fairly good experience even in difficult acetabulums. We have used cemented dual mobility with impaction grafting as well. So initially we had concerns whether a metal-backed cup will work with impaction grafting because normally the traditional results have only been with polyethylene cups. But now I've done this for over 5 years. And so far, at least, I use it very, very sparingly. My concern with dual mobility is not so much the interface failure, but that certainly the SURF still has the old poly. Now, some of the designs are coming up with the new crosslink poly. So I'm more worried about wear. So I use it only for low demand patients and older age patients. For most younger people, I will go for a standard hip and I'll explain the risk of dislocations, take all precautions, and only reserve dual mobility for plan B. So cemented dual mobility with impaction grafting.
Thank you.
Rajeev said you have a question?
Also, you can see how well the impaction grafting had healed in less than 1 year. The entire acetabulum has...
We discussed that. Maybe in the discussion, we can talk more on this. Sir. About the teriparatide. Yeah.
Sure, sir.
Okay. Abhay, is it visible and audible? Can I start?
Yes, please. Go ahead.
Yes,
we can hear you.
Yes, Dr. Professor Shahid. Thank you. At the outset, I would like to thank the APAS team, Professor Shahid, the president, and Dr. Abhay, for inviting me and giving this opportunity. My talk is on fused hip takedown by anterolateral approach, and I'm going to do a case-based talk on this, and then it is going to be purely on the approach alone, not the other technical points which all the other faculty have discussed, and they will be also discussing about the component placements. So this case is going to be purely on in relation to the approach. So 34-year-old male presented to me with this hip deformity on the left side. Very unusually, this patient came to me, but he has got this problem of not able to lie down, not able to walk with a lot of limp. He was walking for quite a long period of time, but now for the past 6 months, he was having so much of difficulty even to get up and turn in the bed. So he came to me with this problem. So he can see the flexion deformity in the left hip, unable to put his foot down on the left side. And also he had got a stiff neck. So he's not able to move his neck. Spine-wise, not much of movements, but it's not completely fused. So even though his parameters for ankylosing spondylitis, rheumatoid arthritis was all blood-wise negative, but still it looks like a inflammatory condition. So this is how he was walking. So he came to me with this problem, and mainly his concern was the left side. Because of that, he is not able to walk properly. The right side, there was not much of flexion deformity, very minimal pain on the right side, but the left side is having this difficulty in walking. So if the X-ray showed the spontaneous fusion of the left hip. So even though it looks like as if you can see the right hip and the left hip, there is some amount of fibrous ankylosis and minimal movement and mild protrusio. But in the left side, there is no much of any space around, and it is fixed in the external rotation. You can see the left side, the lesser trochanter is very prominent, fixed in external rotation. The spine-wise, as I said, there was not much of fusion, anything, but still the lordosis is reduced. There is no lordosis. Hypolordosis is there. This even though I attempted to take this sitting and standing X-ray because he was not able to sit completely. So this is the just before the positioning of the patient after anesthesia. You can see the hip is fused in flexion, abduction, and external rotation. Majority of the time in an inflammatory condition, like in an ankylosing spondylitis, this is the position where it gets fused in a spontaneous fusion. So after positioning, you can see, usually I keep just a pillow between the two limbs. But here in this situation, because of the fusion in abduction, the limb was it was almost like floating because of the fusion. So I had to keep a couple of more sheets to make sure that the limb is not floating and no fracture happens during positioning. So this is how it was positioned. So just to take you down through this anterolateral approach, what I usually do here is, so there was a discussion about the I don't know why suddenly this has got stuck. There was a discussion about the dual approach before this couple of talks. But in this anterolateral approach, what I do is, I don't know, suddenly.
Yeah, we can see you now.
Because I think of the video.
Can we go ahead then?
Okay. It's not going ahead also.
Raj, if you can go to slide sorter and then start with the slide after this slide and then try the slideshow again, it might work.
Okay. Abhay, it is again rotating. If can the next speaker start his talk, I will sort this out and I can start it from that slide. Abhay?
So we can invite Zian.
Dr. Zian to...
Yeah. So,
please.
Okay.
Please.
So can you see the slide?
Yes, we can see and we hear you clearly. Please go ahead.
Okay. Good afternoon, everybody. First of all, I'd like to thank the Society for the invitation, and also thank Dr. Abhay for the effort he made to organize the meeting. So my topic today is about the socket side issues of ankylosed hip, and I'll start with the case. So 34 years male. History of AS for 20 years, present to clinic with reluctant to walk and sit down, and also with mild low back pain. So we easily spotted from the X-ray that the bilateral SI joints are disappeared, and bamboo spine is obvious. Right hip is totally ankylosed, and it seems like there is still some space existed on the left hip. So it's very difficult to get a standard AP X-ray due to the stiffness and twisted body of the patient. So the discussion for this open topic concerning the socket side, I believe, has been widely discussed earlier, including the prosthesis choice and safe zones and advanced imaging and the approach. So I'll give my answers at the end. First, I did P on this patient. The patient has a lumbar spine anterior flexation for 40 degrees and posterior extension for 20 degrees. Both hips lose range of motion, even though there seems to be space left on the left side. So obviously, he's a spine user. So we also did gait analysis, but here I want to apologize because we have a shortage of personnel due to COVID-19, so we do not have stuff to do the documentary. So I'll try to explain with some illustrations. So then CT and MRI were proceeded, and to get more details. So I think MRI is very useful because not only you can find some bony landmarks that can be used as a reference during the procedure, but also be able to assess the soft tissue, like if the muscles are intact, and to stabilize the implants or have a potential to rehabilitate post-operatively. So in this case specifically, we can see that the muscle is more hypertrophic and no joint space on the right side, which may indicate that the left leg is the dominant one and may have a sudden movement. So also we did a laryngoscope to see if there is any trouble on intubation, and we send the patients to an anesthesiologist and also the rheumatology for further consultant of medication use before surgery. So during the procedure, I applied a hot hinge anterior approach, which I think is a very good one for the cases like this. So soft tissue release was followed, and rigid adhesion found between the head and socket with fiber tissues, and no space was actually there. So what I did is to make a subcapital cut just below the head to enable external rotation and adduction of femur. So then I have a visual of entire neck to do the final cut. So as the orientation of the acetabular is might be very confusing when you start reaming. So my tip is that I start with the smallest reamer and ream along the axis of the femoral head. So because in situations like this, it is okay to assume that the head is perfect sphere and the rotational center is just synced with the socket. So after every reaming, you use the spoon to remove the cancellous bone in the bottom of the acetabular. And always you can find the ossified transverse ligament, which can be used as a reference of reaming depth. So this is the post-operative X-ray. So I selected it on cement, a ceramic VS poly cup, and the patient's doing okay. And I was supposed to do the other side this week, but the patient just left the hospital for personal reasons. So here's two more cases. I used the same method to positioning the cup, and all turns out to be okay. And you can look at that. The orientation seems all good. So we also tried to do the cup with a robotic arm assist system, but however, unfortunately, all failed in the registration part. So so far, the robotic system can only be used as a planning tool. So three complications are supposed to be have connected with the cup issues like malposition, etc. It is dislocation, osteolysis, polywear, and also with septic loosening. So a systematic review published lately reported that the most common complications is septic loosening, account for 10%, and polywear may be only one of the main reasons leading to that. And also, surprisingly, dislocation rate is very low, and intraoperative fractures all happen on the femur side. Another retrospective study shows similar results. Septic loosening is still the main reason leading to revision. However, all the polywear occurred in the conventional pulleys. So, and there are only 40% cup position within the safe zone, and only 1.9% dislocation at 5 years. Just like I mentioned earlier, that sometimes total hip can be very incredibly forgiving, especially for cups. So even if I save so many imaging in this case, the patient can still have a very good outcome. So here's my answers to the question. First, implant choice, I prefer uncemented ceramic poly cups because with the evolution of technology, high crosslink poly and improved uncemented fixation makes implants last longer. and also secondly, constrained polyliner is more competent for if a non-ideal positioning happens. So patient with ankylosed hip comparatively are younger, and bone stock is always sufficient for uncemented fixation. So cement, and also one more thing is that a cemented cup actually lost more bone if the case needs to be revised. So safe zone can still be used and used for reference. Cup positioning and ankylosed hip is challenging. Excessive anteversion should be avoided, and I think functional orientations is reliable. Intraoperative range of motion, like I mentioned earlier, and the stability test are the most reliable method, especially under general anesthesia with the use of muscle relaxant. If the plans are stable and free for impingement, it is very likely the patients will be fine. I think advanced imaging do helps a lot, and it give more details about spine-hip relations in many ways. So we should do that if it's possible. But however, it also means more radiological exposure and more money spent. And the sad fact is that even if we did everything, judgment errors still happen. So despite all the information we have, it also hard to accurately quantify the position with our belly hands. So for approaches, my opinion is use the one you're familiar with. So because the nature of the disease, which may have altered anatomy leading to devastating consequences, minimal invasive may not be a proper choice. And also direct exposure is very critical in such cases. So thank you so much.
Thanks, Zian. But before wasting too much time, I would request if Raj is ready with his talk to finish off where we left in between.
He has to stop his screen share.
Yeah, so
Okay,
Zian,
okay.
you'll have to stop screen share.
Okay.
Yeah.
Okay. Thank you. Sorry for that inconvenience. So this is how the positioning was done. And so this is purely the anterolateral approach, what I routinely do for all my cases. So this is a little added advantage here. So after opening here, once you come to the vastus lateralis and the abductor, so I incise the vastus lateralis and then I curve it. I don't go in the middle, and I curve it. This is basically to give a tuft of tissue on the greater trochanter and also keep the majority of the abductors intact. So in that way, it is almost like approaching the joint anteriorly, not purely on the lateral aspect. So going almost entirely on the anterior aspect of the femoral neck and to the joint area. So this is how I put a Homans and a retractor there and try to preserve the abductors as much as possible. So that is once that is done, as everybody said about the double osteotomy or the napkin osteotomy. So here the advantage of this approach is that because of the external rotation deformity, you can see the neck and the trochanteric area almost in the front and in the anterior. So unlike in the posterior approach where you need to go a dual approach as mentioned, open it posteriorly and then come to anteriorly also do the neck. But here the advantage is the approach because you are going anteriorly. So once that is done, then you take a wedge. The moment you take the wedge, you can see that the joint, everything comes in front of you. And once you see that space there, then you take a Shyam. I do a Shyam picture. So to make sure that, see the head there is no joint visible. It's all fused. So the ones after the osteotomy, I take an osteotome or a marker and check it under the Shyam where exactly the acetabulum roof starts. So that gives an idea. Once that is done, do and start the in situ reaming. And once you start the in situ reaming, you know where the floor will be with the multiple perioperative findings. You can do. And also whenever there is a doubt, you check with the Shyam. Again, and then you do the cup placement. The key point here in his fusion takedowns is don't go ahead and do the original cup straight away. Do the cup, keep the trial in situ, check again the Shyam, go and do the femur, and then once the joint is reduced, once again check for stability, and then check under the Shyam. Once everything is satisfied, and then go ahead and do the original cup implant placement. So this is the post-operative X-ray. And 1 month post-operative X-ray, you can see that patient flexion deformity is corrected and able to lie down flat. So in this approach, the big advantage of this approach is majority of this flexion external rotation deformities are addressed in single approach, and there is a very, very less chances of perioperative nerve injuries, where in a posterior approach, the greater trochanter lies very much close to the sciatic nerve. So then osteotomy becomes very difficult. So in this approach, that is a big advantage. Thank you.
Thank you so much, Raj. And I had a question which came very early in the webinar, but I think the correct time for it is now. Yeah. And the question is that what is the incidence of heterotopic ossification in a post-ankylosis conversion arthroplasty? And does it vary between anterior and posterior takedowns? And secondly, how do you prevent it in your exposure techniques?
No, here
I would request Raj and Nikhil to address this one.
Okay. So previously we were all worried about this heterotropic ossification, and we were giving indomethacin prophylactically. But invariable to the approach, whether it is posterior or a lateral approach, anterolateral approach, I don't think nowadays we need to worry too much, because the incidence of heterotropic, I have seen so many cases post even an ankylosing spondylitis or a fusion takedown, very, very low incidence. So I don't think you need to give any prophylaxis for a heterotrophic ossification. So very, very negligible. So, and also the radiation immediate post-op, the radiation is also not needed. One is that. And again, coming to the approach wise, whether there is any difference in the heterotrophic ossification, I don't see any big difference. Nikhil will also like to add upon this. Anything more?
Nikhil, you're muted.
Abhay, I don't know the exact figure to quote based on literature, but the incidence is low. When we talk about incidence of HO, what we need to differentiate is between the odd island of bone that you see in quite a few hips and clinically significant HO that leads to secondary stiffness. So the incidence of clinically significant HO leading to secondary problems is very low. Number two, prevention. Indomethacin can be given, but it has its own side effects. And to the best of my experience and evidence, it does not make a significant difference to the reduction in HO. What makes more difference is meticulous surgical technique. And especially when you're reaming the acetabulum or you're reaming the femur, the bone debris that gets left behind has to be very, very thoroughly washed out. And sometimes we see that people only wash the hip out at the end of the operation. So what we tend to do is every 5 to 10 minutes in difficult cases, I give a nice wash to the hip with pulse lavage, and you keep cleaning the hematoma out and you keep cleaning the debris out. And I think that is the key.
Okay, and then can I quickly get David onto this? He's an extremely experienced surgeon. And David, what do you think is your practice? And do you feel there is a difference between the gateway you choose to get into the ankylosed hip when it concerns heterotopic ossification?
Essentially, you really need to have an extensile approach for all these cases. One that you can, at short notice, just change to something else. And most of us who like this to do an anterolateral approach, but in every one of my cases, no matter what the diagnosis is, I always do a routine total capsulectomy. That just makes it easier for me to do the surgery. And I've never had any problems with heterotopic ossification at all, even with terrible ankylosing spondylitis cases.
And that's a great point, David. And can I just quickly get you all on to another question that probably needs answering, is that do you really differentiate between an ankylosis, between a spontaneous ankylosis and a surgically induced ankylosis? So do these two players behave differently? And do you actually address the issues differently? Starting with you, David, can I request Rami and then Raj and Nikhil to just quickly get onto this?
I didn't quite get the question, actually.
So does a spontaneously ankylosed hip in, let's say, something like an ankspond or a post-infection, post-septic arthritis differ from a surgically induced ankylosis? And do you treat these two animals differently?
No, they just do them the same. That's because I just do a total capsulectomy for everybody. But
Rami, can I get you onto this? Do you think these are two different animals, and do they need a different approach? We have one view that it does not change.
Yeah, they don't need a different approach, but they do need different considerations. So that which is basically fused spontaneously, fairly straightforward, but those that are fused as a consequence of surgical intervention or trauma, as we've discussed, need to be considered in the concept of the abductor mechanism. How traumatized or damaged is that? Because that really is a consequence of a good outcome. If you have a poor abductor mechanism, you're not going to have such a great outcome, or the patient may be dependent on a walking stick for a much longer period of time. So you have to take a more thorough history, see what hardware is actually still in situ if it hasn't already been removed, see where the scars and incisions are, what has been used as the approach in the past. That's all going to come into the algorithm of how you're going to approach the hip joint. So they are different in my world.
Right?
Yeah. Actually, very well mentioned, Dr. Rami. And just to add upon, yes, apart from the abductors, the approach, we have to be very, very careful because the surgically fused are very challenging because of the complexity, because of the metal involved inside. Infection chances are very high. And also the most important thing is you have to be prepared for surprises perioperatively. Once you open it, you see a lot of surprises. You should have all the implants options available in your armamentarium. You should be prepared with various distal loading stems, extra plates, like as one Nikhil showed here, he had to open it and do a long plating posteriorly. So locking plates, long screws. So the approach is totally different when it is non-spontaneous. In the spontaneous,
I never have to do anything if I use cement, okay?
Yeah. So that is a surgeon's preference. But at the end, the preoperative planning is very, very important in a surgically fused. And also you have to discuss with the patient very much in detail. Counseling is very important because post-operatively, there are so much things he has to be taken care of. So.
Thanks, Dr. Raj. So what we gather till now is that
there are two more points.
Dysfunctions and unpredictability. And in your view, Nikhil, how do you think these two are different, if at all?
So spontaneous ankylosis is relevant based on the age at which it happens. If it has happened at a very early childhood, the whole hemipelvis and sometimes the whole of the ipsilateral lower limb does not develop properly. It remains hypoplastic. They don't get good movement, and their abductors have never developed, and the sciatic nerve is shortened. And that is very relevant to when the spontaneous ankylosis happens. If it happens in an adult or a post, when the child's development is complete, it's a different ballgame. The second consideration in spontaneous ankylosis is the position of ankylosis. If it has happened in a reasonably good functional position, it's less of an issue. If it has happened in a very awkward position, it's more of an issue. Now, with surgical arthrodesis, it depends upon three things. Firstly, you can do an intra-articular arthrodesis or an ischiofemoral arthrodesis without an implant. And they don't really cause much of an issue. And many of the arthrodesis we see at Wrightington, and that case that I sent you, if you want to present it, they don't have an implant. They've had a hip spica. So they're easier to manage. But the extra-articular arthrodesis, which is done with a cobra plate or with an anterior mata plate, they destroy the entire abductor mechanism on the supraacetabular portion of the ileum, and they are the nightmare to solve. So it's very important to distinguish these separate categories. These are not all the same animals. They're totally different.
Abhay, can I just make a small comment?
Yeah, yes, sir. Please, go ahead.
Three things are very important here. One is that when you have a surgically fused hip, then fusion has been done with an indication, and mostly you expect that this fusion will be done in a acceptable position of the hip. So that is one thing. And if the patient wants to change that to arthroplasty, his expectations need to be sort of discussed very well. The second is the fibrous tissue formation. When you do a surgical fused hip, there is a lot of fibrosis you expect. And thirdly, and for me, is most importantly, is the possibility of a latent infection, which is surgically induced. And when you send the implant culture and it comes positive, now that probably is one of the major issue for us.
Sure, sir. So basically, I think the take home from the faculty on this is that the two behave differently. And arthrodesis spontaneous ankylosis in a young behaves to some extent like the surgically induced one, wherein the abductor dysfunction is a big problem. And otherwise, the spontaneous ones are relatively simpler to take down. Is that the message which all of you have given forward?
Okay.
Yeah, thanks. So, Sanvi, go ahead to the next talk in the program.
Please.
Yeah. So, can I request our next speaker, which is Dr. Rajeev, to please present his talk, sir.
Thank you so much, Shahid. Thank you so much, Abhay, for giving this opportunity to speak on a very interesting subject. And I'll be discussing more on the surgical technique of this, converting an arthrodesis to a total hip arthroplasty. It's an interesting aspect that how to have a successful surgery in these difficult patients who have been having this problem for a long time. I'll try to explain through two of my cases. You see that this young patient who's just about 26 or 27, he has the bilateral hip fused, spine fused, and the worst thing was that the extension, the fusion is an extension, which results in the inability to sit for this patient, severe back pain, both hips are involved, the sacroiliac joints are involved, hips are having the spontaneous fusion in extension. Severe disability, we can see the x-rays, we can see that both the hips are fused, sacroiliac joints are fused, spine is also fused. The challenges in planning are that, and we must appreciate it very clearly, that they differ from case to case. As we have been discussing so far, number of joints involved. In this patient, both hips are involved, both knees are normal. There is a deformity of the abduction deformity on the right side in 10 degrees and no rotation, internal, external, and left one was in neutral. The fusion was spontaneous, ankylosis was bony. What is important for these patients to be seen is not just the surgery, but what kind of anesthesia is to be given. Sometimes you need a fiber optic support for a general anesthesia because the spine is fused and epidural anesthesia is very difficult. Positioning on table is very important. The surgical approach, which one we have to use, I mostly use the postural approach. Assessment of the pelvic tilt and the spinopelvic relationship is very important to be understood. We have already discussed the Mehul talk. The planning issues are whether you will do both the hips simultaneously or you will do the stage one. If you are doing the stage one at a gap of 3 days or gap of 3 months, if the patient is having a hip and knee both involved, then one side hip and knee to be done simultaneously and then the other side to be taken up. The standard postural approach or the dual approach to decrease the exposure is to decrease the trauma to the patient, to reduce the damage to the abductors, which is very, very important. Sometimes if it is needed, which I'll discuss it through a video, the trochanteric osteotomy is a very easy and good way. Care points are that one must remember that care to the injury to the femoral artery is very much possible, because the femoral artery is very close, and when you're doing the anterior capsulotomy, then it is very easy to damage the femoral artery, and one has to be very careful. And if it happens, you know that you have to involve a plastic surgeon and then suture it back. Over-reaming of the acetabulum is the second major care point. Post-operative fractures, impingement, and malorientation of the cup and the femoral stem. Heterotopic bone should be removed carefully. Neck cut in situ, what we have been discussing, the segmental resection. Care must be taken to avoid too much proximal or distal cut. You must be careful that you don't damage the trochanter. Soft tissue release, iliopsoas and abductors, capsular release. start reaming before removing the head if it is possible. Assessment of orientation of the reaming transacetabular ligament is still maybe a great help. Assessment of the pelvic tilt while reaming is also very important. So in this patient, as we see, the standard posterior approach, careful reaming because the bone is very osteoporotic in all these patients. Over reaming should be avoided at every cost. Uncemented stem, I prefer both stem as well as the cup uncemented. Modular components to restore the hip mechanics and improving the stability. Dual mobility cup wherever it is needed, especially where you have a spinopelvic angle is deviated too much. Use transfemoral, the TFL or gluteus maximus or iliotibial bend to augment abductors if it is damaged or if it is very weak. Iatrogenic fractures can happen over acetabulum, as I discussed. Insufficient bone contact for the cup. Component loosening is very easy because of the porosis of the bone, and you don't have a exact parameters as you have in the normal hip. Heterotopic ossification, I give the prophylaxis of indomethacin, 75 milligram per day for 6 weeks. Radiotherapy is indicated in the literature, but I have not been using it. Impingement is a problem, and one has to assess very well what kind of a rotational, the abduction and the inclination of the cup, anteversion of the cup to be used. That's what this patient that we have just been discussing. At a period of 1 year, this patient is having a good function, able to sit comfortably, though the hip flexion will remain limited in these patients for quite some time. But you can have a reasonable function in these patients. They may not be able to sit on the floor. They may have the impingement when they flex it beyond 90 degrees, and that part has to be explained well. Now, the next one is a very difficult situation. That's what you see here. The hip is fused in abduction, flexion, and external rotation. A very short video in this patient. Now, in these kind of patients, I prefer to do the anterior release as well by a separate incision, removing the at the intersphalic spine. That's what we see here. And as we have been discussing so far, the hip will remain abducted in this kind of a situation, which has to be supported well. That's the anterior release we are doing here. Because these are the tough cases, and here the release is very, very important if we want to protect the patient from a peroperative fracture. That's for the exposure. And on the table, I realized that it is not possible to go from the posterior side. So as Raj has been explaining, the similar approach can be done. You can open have the approach, lateral approach, and you can open the hip anteriorly, carefully, because the patient is having a abduction and flexion. Have a double osteotomy of the neck, and be careful that how you are moving the fragments. And that's what you see in a very easy way. You can remove it. You can see that the acetabulum is the part of the femoral head is still there. You can use the high-speed burr in these cases, which is very useful. And you can ream over the remaining femoral head. It is much more easier by that way. And after the fixation of the acetabular cup, it is very important that you remove the anterior osteophytes or whatever the anterior bone is available. And in these cases, it is very important that you use the trial cup. Unlike the routine cases, you keep the trial cup, do the femoral stem, and see that how is the correlation of the two in various degrees of flexion and extension. The cup fixation is very important. That cup should be fixed in the right orientation. There should be a combined anteversion of the cup and the femoral stem is very important. In this patient, we have the trochanteric osteotomy, because that makes it easy to protect the abductors. And as we were discussing, the anterior osteophytes or anterior wall should be reamed out to avoid the impingement. And the trochanteric osteotomy can be fixed very easily. That's what you see here. The patient is, you've been able to bring it back to a reasonable position. In patients where you have all the four joints involved, the fusion of the hip, both the hips, fibrous ankylosis of both the knees, flexion deformity. I'll just go through quickly. The biggest issue in these patients, in my hand, is that the over-reaming of the acetabulum is a major issue, and what we see on the right side, that should be avoided as much possible. Thank you so much, Abhay.
Thank you, sir. And while we are collecting questions, may I quickly request Professor Shahid, sir, for his talk. And then once we have collected all the questions that are coming in, we will proceed with the discussion. Shahid, sir, may I request you to please share your screen for your talk on femoral side issues.
Shahid, you're still muted, Shahid.
Okay.
We can't hear you. Yeah.
Can you see? And I'm just going to do a full screen. Can you hear me and see the screen, please?
Yes, sir. Yes, sir. Absolutely.
Thank you. I'll just quickly go through. I'm just not going to repeat. People, the audience of this webinar should understand that this is a very challenging surgery. Even though it's an elective surgery, it should be done by a very experienced person, ideally by a revision arthroplasty surgeon. And careful preoperative clinical and radiological assessment is mandatory. The surgeon should be well versed with extensile approach, including doing trochanteric osteotomy and extended trochanteric osteotomy, and all equipment should be available. Choice of femoral component. Implant selection depends on the quality of the bone, presence of cortical defect or stress riser that are related to hardware removal, and be prepared for surprises. Choice of implant, if the femoral component is primary and anatomy is normal, then we can use a primary cemented or uncemented implant. In difficult cases where you have to get the orientation right, S-ROM Johnson & Johnson component with metaphyseal sleeve can be used for metaphysio-diaphyseal mismatch, as well as correction of the neck version and offset. In case where extended trochanteric osteotomy are done and corrective osteotomy of the proximal femur are done, a diaphyseal fixation implant are used. This could be a modular or non-modular. So quickly coming to the case, the first case is a 55-year-old female. She had a congenital bladder dystocia associated with pelvic deformity. She had been managed with ileostomy and external urinary bag. She had septic arthritis of her left hip 30 years back, requiring hip arthrotomy and antibiotic. This led to left hip arthrodesis in a non-functional position. These are her x-rays at presentation, and you can appreciate the left hip fusion and pelvic diastasis opening. This is the lateral view. This is this 3D reconstruction, the frontal view and a lateral view and the posterior view. And her hip has been fused in 70 degrees of flexion, and she has a limping gait. She has a short limb gait. So she came to our service with severe low back pain and difficulty in mobilization. Her labs are within normal limit. The question is, how would you manage this patient, and would you do anything to the pelvis in this particular case? So we have faculty in the panel. How would you deal with the pelvic and femoral component? Can we have opinion, please, Nikki?
Do you have any CT scans, any axial, coronal, surgical images, or 3D reconstructions?
I do have.
How long has that pelvis been like that?
For 24 years.
And she has mainly come to you with back pain and a fused hip.
Yes.
So my gut feeling is that if that pelvic deformity and separation is 24 years old, then not to go looking for trouble, to try and change that, and to try your best to just focus on the hip, if that's what the plan is.
Okay. I agree with you totally. We've had discussion with our pelvic team, and we made a decision to leave the pelvic deformity. And these are intraoperative video, and you can appreciate about 70 degrees of fixed flexion contracture, and you can see multiple scar anteriorly. So we decided to do a posterior approach. These are intraoperative pictures where we have done osteotomy, double osteotomy. This is the view of the acetabulum. We've prepared the acetabulum, and we've put uncemented dual mobility cup. And the femur was fine, a normal anatomy of the femur, and we use a primary HA-coated implant. These are intraoperative pictures. And this is intraoperative range of motion of flexion, as well as full extension. And these are post-operative X-rays, and she has been mobilized full weight bearing. She's 1 year down the line, and she's making pretty good progress. Coming to the second case, this is a 54 years old patient with severe disabling low back pain. He had elective surgery of arthrodesis of his right hip done elsewhere when he was 34 years old with a Jewett blade plate. His ipsilateral knee and contralateral hip are asymptomatic. His lab works are within normal limit, and he has been counseled about outcome and possible complication. So with this metal work in place, how would faculty deal with this particular case?
Rami to come on this, very similar to Nikhil's case.
Yes, thanks, Abhay. Look, this is when you find metalware that you've never put in yourself and never extracted yourself, the first thing you need to do is consult someone who's familiar with the product. Now, there's no problem taking the screws out, but these are so old, they may even be Phillips head. They may be soft metal that's difficult to remove. So you're going to need the screw removal set to make sure, and you may want to do this in a staged procedure, I might say, where part of the operation is actually taking the metalware out, closing the wound, then come back on another day, because you just may run into some difficulties. The other option is, if you can't get it out, you may have to do a resection of the neck and take the biscuit out around the metal implant, break it up, and then pull it out. There's a few complications here that you can run into. The femur itself, the morphology is fairly straightforward once you've extracted the metalware, and you'll put in a long stem cementless is what I would use, distally based fixation. And the cup is nowhere near as complex as the first case you presented there, Shahid. At least you know the anatomy is relatively normal here in terms of cup placement as opposed to the last case. But I think metal extraction here is the complexity in this case.
I agree with you. So we have, because these are very old metal, I have never used this in my training in UK and in Pakistan. So sometimes these are Philip screw head. So we've had all the inventory available. So we were lucky that we were able to remove the implant easily, and we've not had any broken screw. But so you have to be prepared with all equipment and inventory. And you will have surprises. So these cases should not be attempted by young arthroplasty surgeon. They should be attempted by experienced arthroplasty surgeon, and you should have all trauma inventory available. So implant was removed. It looked all well. Preoperative clinical assessment and lab workup were within normal limit. So we did osteotomy and we prepared, and this is acetabular preparation and placement of uncemented dual mobility cup. And femur is a male. We had long femoral component available. We understand the stress riser of the screws, but it was a pretty solid femur. So we opted for a standard fully HA-coated coral type of implant. These are intraoperative pictures, and these are post-operative X-rays. Standard fully HA-coated implant. And his leg length is restored. And is mobilizing full weight bearing, some issues with the so patient is happy. He is 1 year down the line, and so these are challenging cases. And the basic message to the audience is that you should have all inventory of trauma and all type of implant available. For diaphyseal fixation, for accidental fracture, you should have a trauma implant available, and preoperative planning will help in avoiding surprises and complications. Thank you.
A lovely talk, sir. And before I go on to the final talk of the webinar, which is how to deal with the complications by Professor Rajesh Malhotra, sir, can I request Dr. Rajeev sir and Dr. Malhotra sir to give two very good, quick take-home messages for acetabular side issues, and two very quick take-home messages for femur side issues, and then a final word from Dr. Shahid sir.
See, for the Rajesh.
So two quick messages for the audience, sir, for what we need to remember on the acetabular side and what we need to remember on the femur side.
For the acetabular side, the first thing is the approach. The segmental osteotomy is a very good way. You need not remove the femoral head. You can start reaming the femoral head when it is still in the cup, in the acetabulum. That way, you will take out a good quality graft, which you can use to fill up in case you are over-reaming a little bit. And then after, the orientation of the cup is very important. If it is...
David, some patients drop the blood pressure, but it doesn't go down that badly. And actually, we don't have this issue. It is people like Peter Chung who do. Peter Chung has a major problem with this because he goes through tumors. And when you put cement into tumors, they really drop their blood pressure and die.
We would conclude. And I'm extremely grateful to all faculty, starting from Professor David Chung, that you have allowed us to establish this Asia Pacific Hip Society. I'm extremely grateful, Rami, for your presence all across, and all faculty, Mehul Acharya, Chunoy, Nikki, your presentation and comment from Wrightington has been excellent, and I've been trained in UK, so I'm also a cement lover. Raj Kumar, the Secretary of Indian Arthroplasty Association, your comment has been excellent. Zhang, your Singapore, your presentation on the acetabular side, excellent. And Rajiv, you are very experienced, and Rajiv is a good friend, and we have met at many places at FAS and across the globe we have met. So thank you very much. And Sir Rajesh Malhotra Saab, Sir Salam. So you are a master of, your presentation is mesmerizing. And you've shown all possible complication and prevention, and working for such a long time. I'm sure a lot of your students are working as professors and senior consultant across the country and working across the globe. I'm extremely grateful to you, sir, Professor Amin Chinoy Sahab. Professor Amin Chinoy and I being a class fellow in medical school, so he's a very good friend. And Abhay has been the pillar of this webinar, and it has been excellent. It has been a great learning experience for all of us, from conventional cemented total hip arthroplasty to most modern investigation. But the take-home message, if I can conclude, is that these are difficult cases. And the first thing a young arthroplasty surgeon who has done a fellowship must understand that these are difficult cases. These are not to go and get a routine total hip replacement. And this requires a lot of planning. It's an elective surgery, should be done by most experienced surgeon. You should have all possible inventory available. And finally, all faculty, I would announce that the next webinar will be on Saturday, 14th of May. And we are, as has been mentioned in the beginning, that we've already have faculty from Japan and 2 faculty from India, 1 faculty from UK, who are going to talk on a very difficult topic again, dysplastic hip, because these dysplastic hip are done in young patients. And we must get it right first time, so that their arthroplasty should last at least 2 or 3 decades. So these cases in dysplastic should also be done by very experienced surgeon, correct surgical technique, correct implant, correct bearing surface, that they should have a good quality of life for next 2 to 3 decades. So extremely grateful to all faculty, and I'm sure that the viewer of this webinar would have learned a lot of things. This whole webinar has been recorded and it will be placed on the website of Asia Pacific Hip Society. So thank you very much, and have a good time, good weekend.
Thank you so much, sir. Thank you all faculty. Thank you, audience. And this webinar will be available on the APHS website. Thank you all.
It was a pleasure meeting all of you.
Bye-bye.
Thanks a lot.
Thank you.
See you guys.
Bye-bye.
Thanks, everyone.
I think, admin, we can stop recording the webinar.
Yes, sir, we are now offered. If you want, you can communicate among yourselves, sir.
Yeah, thank you so much. Thank you.
Well, thanks for that. It was good fun.
Thank you, David.
Thank you,
Thanks
Rajeev.
for being there.
Thanks, Rajesh.
It was a wonderful discussion.
Thank you so much.
Nikki,
Thank you so much, sir.
Thank you very much indeed.
So Nikki's and David's love is cemented.
We love evidence.
Yes, sir.
And also,
We
if
love
you
convenience.
I think what is important is to be familiar with everything, and be able to master it and do it very well. Absolutely. But you should still have your main go-to for most cases and sufficient experience to change the plan if required for complex scenarios. I think the days where you are a one-trick pony are long gone.
And if you look at the registry data, and David is going to agree with me, that if you look at on the femoral side, in registry data, cemented femoral component done correctly has got equally good result as uncemented implant. And so combining it with a better, especially in the 70+ patient. And if you combine with good bearing surface, cross-link poly, then it might have an even better result. Charnley from Wrightington had shown good result of 20 years with conventional poly. So good cementing technique, right implant, good bearing surface would produce a very good result.
I think the argument has shifted away from using cement or no cement to use whatever you want to use, but get good training at it. Be really well trained. Identify the top 3 performing uncemented prosthesis or the top 3 performing cemented prosthesis, and then learn them well, and then just do what you want to do. It works.
The irony, Nikki, is that in revision we are all using uncemented, very expensive implant, and the Exeter technique of impaction bone grafting is actually dying.
I've just written I've just written a book chapter on femoral impaction grafting for Springer.
We all have written this stuff, Nikhil. Nobody reads it.
I know.
On the acetabular side as well. And it's very relevant in India, Pakistan, Bangladesh, Sri Lanka, Malaysia. And that this skill needs to be revived and revitalized because this is cheaper.
We should do one where it says, what is the cost of what we do?
Yes. And I review my cases, and I've been using the posterior iliac crust graft. In the beginning of my career, I did not have the access to bone bank. So I've been using autogenous posterior iliac crust graft, very juicy. You can take a 0.5 kilogram of graft, and it's and it has been working. So it has worked very well. So these are the techniques that we need to train in India, Pakistan, Bangladesh, Sri Lanka, Malaysia, and so cages works very well with impaction bone grafting. Rajesh, your opinion?
Yeah, definitely, absolutely. I personally am a great fan of impaction grafting. If I had a failed stem with an intact endosteal tube, even if it was a revision stem, I would like to see if I can do impaction bone grafting and put a short stem in place in a young guy to buy him a few more years and some more bone stock. So and even on the acetabular side, I think impaction bone grafting is a great technique, but maybe I'm not a master like Nikhil, so I combine it with the injectable, the calcium cement, so it gets into the interstices, becomes rock hard very soon, and I'm able to put them on early weight bearing compared to just pure and simple impaction grafting on the acetabular side, because I use it with the cementless cup, and I'm sure you do it with the cemented cup. So that is not an issue with you to put them on immediate weight bearing.
So I've done it with cementless cups as well. What is important is you don't compromise the host prosthesis interface by too much impaction grafting if you're going to use it with an ultra porous cup. You have to have good host bone contact, and the remaining areas where you don't have contact, you can fill it up with bone.
So wherever possible, aim for contact between the porous surface and the host bone.
Because that's how it's going to work.
Fill it up with the
Correct.
I agree.
And that's why it's important to be familiar with all techniques,
So we'll
also,
take a lead.
Rajesh has developed a fantastic bone bank in AIIMS, which is enviable. The work that he has done at AIIMS is amazing.
I just 3 weeks back, I revised tumor prosthesis in a 23-year-old who had his lower half of femur taken out for a tumor at the age of 14 years. And I replaced it with an APC. And I didn't have long enough stem to go with the hinge. So I combined it with an antegrade nail through the host bone, going into the half the femoral length of allograft, and then with the striker hinge. It was fun. Very interesting exercise to show. Yeah, but he'll take about 3 months to start full weight bearing. He's just on toe touch. So these things do take time, but once they happen, and it is also integrated at the junction, then I think I've got 20-year results of massive APCs doing very well.
One of our British trainees visited AIIMS a few years ago as a reverse fellowship, and he was mesmerized by what he saw Rajesh was doing and Vijay Kumar was doing in tumors and in bone grafting and mega prosthesis. So, terrific work. And he's still not invited me to AIIMS.
Okay, I'll invite you. Come on in, be the visiting professor.
Thank you so much, everyone.
Thank you, Rajeev. Thank you, everybody.
Thank you so much, sir.
Okay,
It's been
bye.
fun.
Okay. See you.
Bye.
Bye. Bye.
Thank you.
Thank you.